white man comes to physician because his wife is concerned about the freckle on the back of his neck. He says he has had a freckle for many years, but he has noticed that it has grown during the past 6 months. Brother died of liver cancer at 50. Exam shows 3 centimeter lesion at the base of the skull. Um, Photograph of the lesion is here. Reminder of the exam is fine. Which of the following is the most appropriate next step? Ready?
Yes.
Okay. Oh, I didn't even take.
Uh,
Uh, oh, this one doesn't have the other explanation. Just the.
okay. Full thickness maps. Okay. This patient has long-standing benign lesion that has grown significantly in size on a sun-exposed area during relatively short time. The patient's photograph shows an irregular lesion with different colors, which makes it highly suggestive of melanoma. For melanoma, any biopsy technique or rather than full thickness biopsy inappropriate is inappropriate as the depth of the lesion is important to determine. Is should be appropriate.
What
What
do
is
you
the,
mean?
like in the explanation they said that full thickness biopsies, oh sorry, other than full thickness biopsy. Okay, sorry.
Uh-huh. Uh-huh. Okay, next. 24 woman has intermittent fever, malaise, and intermittent fever, malaise, and generalized rash. For 2 weeks, temperature is fine, pulse is fine, respiration fine, blood pressure fine. There is generalized redness, erythematous maculopapular rash over palms and soles. She has patchy alopecia of the scalp and eyebrows. Hematocrit, I don't know, I'll check. Leukocyte count is fine. Segmented neutrophils, I believe that's high. Lymphocyte is fine. She's giving IV penicillin G. 2 hours later, she has severe chills, headache, tachycardia, flushing, hyperventilation. Temperature is high, BP is low. Which of the following is the cause of her acute symptoms? Acute condition, sorry.
The patient has syphilis
Um, I guess, yeah.
and penicillin is given. So, okay.
Okay, ready?
Yes. So it's a Jerick-Herxheimer reaction. So the patient received penicillin. The patient receives penicillin for treatment of subacute infection that is consistent with tick-borne illness such as Rocky Mountain spotted fever. However, the worsening of the condition after penicillin points strongly to the presence of Jerick's-Herxheimer reaction. This is caused by direct injury to bacteria and results strongly to the presence of Jerick's-Herxheimer reaction. This is caused by direct injury to the bacteria results in the release of the endotoxin such and causes the signs of the sepsis. Patients typically are at risk of shock, but these typically self-limiting. Okay.
Mm, what? Okay, so why they treating Rocky Mountain spotted with penicillin? I thought that was doxycycline for Rocky
Doxycycline is
Mountain.
a one sort of they are using actually penicillin G and doxycycline in Rocky Mountain spotted fever. Doxycycline is a drug of choice, as far I remember.
Yeah, but I
So
guess you can also give penicillin.
they haven't written here, but you can use penicillin as well. If
Okay.
doxycycline is not available, then you can give penicillin. But after giving penicillin, this reaction starts. So he has actually underlying the syphilis, and there is a maculopapular rash in this patient in the palms and the sole.
Okay. Okay. Next.
Content.
53. 53 man notices a lump on his neck. Exam shows hard 2 centimeter nodule in the left, in the lower left wall of the thyroid gland. Needle biopsy shows papillary carcinoma and he undergoes total thyroidectomy. 5 days later, he reports facial numbness and tingling, muscle pain, and hoarseness. Physical exam shows laryngeal stridor and a positive chopstick stick, whatever sign. Which of the following is the most appropriate management?
Okay, total thyroidectomy done. Maybe subconscious, unconsciously, parathyroid gland is also removed.
Mm, mm, mm.
These are the signs of like Vostek sign.
Yeah, but they're saying that the facial number blah, blah, and hoarseness. Okay, okay,
Laryngeal
ready?
stridor. Okay, there is. Okay,
Maybe I'm probably wrong. It's probably just the. Oh yeah, calcium
okay, it's
gluconate.
calcium gluconate.
Hmm?
Okay, I'm reading the why it is not endotracheal intubation. Where is the option?
Mm.
Okay, I'm reading the whole explanation. The
Okay.
sorry,
Yeah, read the whole explanation.
the patient is like when you start seeing the endotracheal intubation, then I again
Mhm.
recheck it because it uh, these questions are confusing. Yesterday we have done plenty of mistakes. Okay, me, I have done plenty of mistakes. Okay, the patient is exhibiting signs of severe hypocalcemia due to acute hypothyroidism. A known complication of the thyroidectomy, immediate treatment is IV calcium gluconase is warranted. While the patient have evidence of stridor, he does not yet show signs of respiratory compromise, and treatment of the hypocalcemia should be abate the laryngospasm, making endotracheal intubation at the time inappropriate. At the time, inappropriate high dose vitamin D, often used in chronic management of hypothyroidism, but it is not indicated in emergency situation. Corticosteroid may induce tetany in hypothyroid patient and would be inappropriate at this time. Administration of 0.9% sodium chloride by diuresis would be appropriate in the management of hypercalcemia, but would not be appropriate in the this management. Okay,
Next. 47 man comes to physician, 3-month history of intermittent abdominal pain. He also has had rectal pain with bowel movements, rectal pain with bowel movement, and occasionally notices trace of blood in the stools. He has diabetes, BPH, hypertension, medication, insulin, tamsulosin, lisinoprostol, verapamil. Was added like 4 months ago. Colonoscopy performed 1 year ago is fine. He's in no distress. Uh, Blood pressure a bit low. Moist mucous membranes. Abdomen is distended and non-tender. Prostate is enlarged and there is an external hemorrhoid. Rectal exam shows hard stool in the rectal wall. Sensation to light touch and vibrations is intact over the lower extremities. X-ray of the abdomen shows multiple F3 levels and stool throughout the bowel. Which of the following is the most likely cause of this patient's current symptoms? Bowel movement.
multifoliar fluid level.
No,
Sensation to
not
light
at this.
vibration. Sensation to light touch and vibration. It's intact.
Yeah.
Where
Ready? Oh.
calcium causes constipation. Okay. With the presentation of abdominal pain, with the presentation of the abdominal pain, pain with bowel movement and intermittent hematochezia, and external hemorrhoid and constipation is most likely cause of the patient's symptoms. Dose-dependent constipation is well-known side effect of the verapamil. Dose-dependent constipation is a well-known side effect of the verapamil and can be seen in up to 25% of the patient. 25% of the patients and given timing of symptoms after verapamil was started, it is most likely the cause. While the colon cancer cause abdominal discomfort, constipation, hematochezia, a normal colonoscopy just 1 year ago makes much less likely. The presence of moist mucous membrane makes dehydration leading to constipation much less likely as well. Okay. Diabetic neuropathy can lead to motility dysfunction in the GI tract at gastroparesis. Okay.
52 women hypertension and type 2 diabetes admitted to the hospital because 2-day history of confusion. She's left hand dominant. Her medication are lisinopril, metformin. The admission, she's awake and alert. Temperature is high, pulse is high, BP
So
normal. On exam, muscle strength is 5 out of 5 bilaterally. Sensation to light touch and pinprick is intact. Coordination normal. She cannot recall a name and address after she cannot recall a name and address after 5 minutes. T2 weight MRI of the brain is shown. What's the most appropriate pharmacotherapy?
she has fever. Is it like herpes simplex encephalitis?
Mm, 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 mm.
He has altered consciousness, isn't it?
Not really. I mean, he says she's confused, but she doesn't. Coordination is normal, and mm, mm, maybe it doesn't make sense. Oh, maybe that one. Ready?
Yes.
Oh, you were right.
Okay. So this patient this patient is a 52-year-old woman. Is a 52-year-old woman. This patient is a 52-year-old woman who comes to the office because of encephalopathy, but no other neurologic findings on examination. She is afebrile meningitis and encephalitis. She is afebrile meningitis and encephalitis are concerned. MRI shows hyperattenuation of the temporal lobe. Hyperattenuation of the MRI show hyperattenuation in the temporal lobe, making herpes simplex encephalitis most likely the diagnosis. Thus, acyclovir is the best option. Okay.
Okay. Previously healthy 52 men comes to physician because of 6 month history of cough, productive of white sputum. He has had no chest pain. He has smoked for like 25 years. Pulse is fine. Respiration fine. BP is fine. Breath sounds decreased with a prolonged expiratory. Pace cardiac exam shows no abnormality. Spirometry shows FEV-FVC ratio of 0.65. Which of the following is the most likely explanation for these findings?
Isn't it restrictive lung disease? Smoker.
I thought this week.
Sorry, sorry,
What's the
sorry,
name?
sorry. Obstructive lung disease. Sorry,
Hmm.
it is obstructive lung disease. And patient is a smoker. Is it COPD? Like infection.
Diffuse infiltrative disease. Infiltrative disease. Systemic-mediated bronchospasm and edema. Mass effect in peripheral lung parenchyma. Hmm, doesn't make sense. Thick flora. Alveolar destruction.
There is no mass lesion, isn't it? And
Mm-mm.
there is no histamine, like it is not asthma, not look like asthma.
Mm-mm.
It is COPD,
Diffuse infiltrative disease of
alveolar
the lung,
destruction.
lung parenchyma. Oh, anyway, ready?
Okay, yes. With chronic cough more than 6 months, with chronic cough more over 6 months, significant smoking history, and physical exam suggestive of hyperinflation with expiratory obstruction, The patient's history and exam are commonly suggestive of chronic obstructive pulmonary disease or emphysema. The FEV1 by FVC ratio is less than zero point 0.7, essentially confirms the diagnosis. The pathophysiology of the emphysema is predominantly that alveolar destruction and fibrosis. The diffuse infiltrative lung disease such as idiopathic pulmonary fibrosis or diffuse thickness of the pleura would most likely lead to restrictive pattern on spirometry with decreased FEV1 by FAV with a FEV1 by FVC ratio more than 0.7. Okay.
Okay, previously healthy 22 men brought uh, to the ED 1 hour after he was hit in his right flank by a hockey stick. He reports no blood in urine. He rates his pain a 6 out of 10. Pulse is high, BP high. Exam shows moderate tenderness to palpation over the right flank. Hematocrit, well, that's fine. Urinalysis shows no abnormality. Which of the following is the most appropriate next step in diagnosis? Hmm. Let me see hematocrit. I believe in 42 is okay though. Where is hematocrit? Hematocrit. Yeah, yeah, it's okay. Hmm. Spiral City. Spiral City. Ready? My pen.
Okay.
Ah, wait, looking for my pen. Okay. Seven.
Okay. We are right.
Okay. Mm-hmm.
The patients with blunt trauma, the patients with presence with blunt trauma to the flank, which may result in renal traumatic injury in the absence of hematuria on urinalysis, the likelihood of renal trauma is low and no further imaging or evaluation is required. He is not showing any hemodynamic instability or active bleeding. He is not showing any hemodynamic instability or active bleeding, so urgent surgical intervention is not warranted. Okay.
Okay. 24 women, gravida 1 para 1, comes to physician because of 3 month history of fatigue. Menses are regular with no excessive bleeding. She takes no medications or vitamins. Exam shows no abnormality except for pale conjunctiva. Hemoglobin is low. Blood smear is shown. This patient most likely has a deficiency of which of the following? Mm. Mm, 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 mm. Ready?
Oh, 1 minute.
Okay. Mm,
Okay, is it the previous concept like
What pre?
iron first? Like previously, we have found a question
Uh-huh.
like yesterday, like where we found that iron is should be looked first.
I think I chose iron, so I'm thinking it's a similar concept.
Okay,
I'm thinking.
and there are like tensile cells. Okay,
Mm.
a premenopausal woman with anemia who has regular menses and no other history of the nutritional deficiency would most likely have iron deficiency anemia. Blood smear show hypochromia and support the diagnosis. Okay, there is nothing to say here. We have to deal with this question just seeing at the PBF.
Mhm. 62 woman comes to physician 8 days after she had lost consciousness while combing her hair. She says she felt lightheaded before she passed out. During the past 3 months, she has had two similar episodes and has noticed that her left arm tires easily. She's left handed. She has hypertension treated with thiazide and atenolol. She smoked for like 40 years. Then pulse is fine. Blood pressure is high in the right arm. Heart sounds are normal. Radial and brachial pulses are absent on the left and present on the right. Ah, okay. Pedal pulses are decreased bilaterally. Muscle strength and sensation is normal. Um, which of the following is the cause of these patient symptoms? Hmm. She say heart sounds. Let's see what to read. I know this is.
The absence of the left and
It is a little.
decreased
Transient ischemic attack. Cervical rib.
loss of consciousness.
Ready?
Okay,
Okay.
okay. This patient has subclavian steal syndrome, which is proximal stenosis of the subclavian artery, Physical examination show there is absent of left-sided pulses, hypertension, history of smoking, cardiovascular, weakened leg pulses, which is likely presence of peripheral vascular disease, together support the diagnosis. The still comes from the vertebral artery flow to retrograde vertebral artery flow to the affected arm, which leads to loss of consciousness. Okay,
Can you read B?
yes. A cervical reef can cause vascular symptoms of a weakened pulse in the left arm, but typically it would not lead to syncope and could occur much earlier in the life. Okay.
Okay. What is it? Then 62 woman comes to physician for follow-up. BP was high 3 months
Why
ago,
you
and
choose subclavian still syndrome? What are the key points have you found on that?
no, there was no key points. I just deleted all the other ones.
Okay.
So I was between B and D. I was between the left cervical rib and this one. And then I just assumed because usually the cervical rib
Cervical.
thing will affect the brachial plexus. So it will cause some kind of like nerve issues. But here they said the muscle strength and sensation, everything is normal. So that's why I went with the Still syndrome. But I don't. I remember we had a question and we looked at the Still syndrome thing. I just don't remember even the image. But I remember we looked into that and we like tried to figure out how it works and all that. But yeah, I don't remember.
Okay.
62 woman comes to physician for follow-up exam. BP was high 3 months ago, and but you were able to eliminate all the other ones, right? All the other
Yes.
options. Yeah. Okay. Got it. Yeah. It was high 3 months ago and high 6 months ago. No. Yeah, it was higher 3 months ago and it was still high 6 months ago. She has 5 year history of type 2 diabetes, control with metformin. Only other medication is aspirin. She has tried to limit her sodium intake and reports moderate success. Pulse is fine. BP is even higher now. And fundoscopic exam is fine. Um, S4 is heard. Urinalysis, glucose negative, protein 1 plus, RBC none, WBC none. ECG shows no abnormality. Most appropriate next step in management. Oh, ready?
Yes.
Okay.
The patient is a 62 years old man who has had two consecutive measurements of elevated blood pressure and the diagnostic of hypertension. Proteinuria was present and the available option lisinopril is the most evidence-based medication to delay the onset of the kidney disease in patients with type 2 diabetes mellitus and hypertension. Okay.
Can you read C and E?
While hydrochlorothiazide and metoprolol would improve our blood pressure, they do not have the same renal effect.
Okay. 11:35. I like this CMS. It's like short questions. 35 men has had recurrent episodes of dysuria, pelvic pain over the past 2 years. He's sexually active. Exam shows tender prostate. Urinalysis 2 to 5 to white blood cells. Urine culture negative. Um, what is the cause? I'm guessing of a dysuria and pelvic pain.
Culture tender prostate, not sure.
Ready?
Wait 1 second. Is
Okay.
actually act as tender prostate. Um, okay. What is the clue have you found in this question?
I think chlamydia will be the only one here that causes prostatitis. I think chlamydia and gonorrhea. I'm not sure gonorrhea, but I know chlamydia for sure causes
Okay.
uh, prostatitis.
In this patient, the presentation of recurrent dysuria and tender prostate on examination is consistent with chronic prostatitis. While the most common etiologies agents are gram-negative rods, such as E. coli, and a negative urine culture should prompt evaluation of the chlamydia in sexually active men. Okay. Other things I can exclude. Okay.
Okay, so it's E. coli and I guess chlamydia.
E.
Yeah.
coli and chlamydia, yes.
Yeah.
And
Uh,
Trichomonas vaginalis can cause urethritis, a rare cause of urethritis in men.
oh, really?
Yes,
Trichomonas.
written in the last line.
Oh, okay. Didn't know that. Carolina vaginalis. 32 men comes to physician because of 4 week history of moderate numbness and weakness of his left hand. There is no history of trauma to the hand. He has hypertension treated with enalapril and diabetes with insulin. BMI is fine, temperature fine, pulse fine, respiration fine, BP is a bit high. Exemptions atrophy of the hypotenar muscles. The middle ring and small fingers are held in flexion. There is weakness of abduction of the small finger. The patient cannot prevent paper from being pulled through his fingers. All other intrinsic hand muscles are normal. Deep tendon reflexes are 1 plus at the left brachioradialis, biceps, and triceps muscle. Sensation to pinprick is decrease of the palmar aspect of the left ring and small fingers and the hypotenuse whatever region. Reminder of the exam is fine. Cause of the findings. Hmm. Oh, forgot the order.
Lots of things.
Yeah, I forgot the
There is muscle atrophy, numbness, weakness,
Jesus. Here you need to know the
the
brachial
middle
pressure.
or
I did. I have no idea on this one.
like
Um,
hypothenar goes with the ulnar nerve, isn't it?
I know, yeah, but he's
But
also
there are
having,
lots of. But I
yeah.
think that like if it is syringomyelia, it looks like cape-like lesion.
No, it's not. It's definitely not syringomyelia. It's not that. It's
Um,
between the. It's like, but I forgot the branches of the brachial.
yes, branches of the brachial plexus, upper trunk, lower trunk. You are talking about this.
Yeah, I don't remember.
Medial cord. You are talking about this.
Yeah, I just don't remember.
Lateral is musculocutaneous and medial is ulnar nerve. Medial cord. What is
I'm not gonna lie, I don't remember this ones.
C8 nerve compression. There are lots of.
Ready?
Okay.
Oh my God, that was my first answer. That was my first answer. But I was like, it's
I
because
was
uh,
I
oh
I have nothing to say.
no, but we knew it was ulnar nerve was
Yes,
involved, but it was because the brachioradialis and the biceps, and so I was like, okay, has to
everything
be,
like the
yeah,
hypothenar wasting goes
yeah.
with the ulnar nerve.
But I thought it had to be far up because all of these ones are also involved, the biceps and triceps. Anyway, whatever
Okay.
with it.
The patient comes to the office because of weakness and muscle atrophy of the medial aspect of the left hand. This is most likely caused by neuropathy of the ulnar nerve. This is most likely caused by neuropathy of the ulnar nerve. Syringomyelia might cause similar symptoms but would typically affect both hands and can cause deficits over temperature sensation and C8 nerve root compression lesions on the lower trunk and medial cord of the brachial plexus will not cause the constellation of the symptom.
This
They
is
don't explain it
yeah, as well.
in a good way.
These explanations are like short and like the person didn't even want to bother to explain anything.
Okay,
It's
if you want, okay, you do it in front of me. Just copy whole thing and paste it in the Gemini.
okay. Like copy this.
Yes, from A to from the very beginning. Yes, from here to total.
Oh, from
Yes. Okay.
Jesus.
I don't know. Yes, now.
Yeah.
Yes, now. Copy.
It doesn't let me copy.
Okay, I have the option.
Okay, make the control copy. Maybe it will tell
Yes,
me.
control copy and then just paste in the Gemini, not in the Google.
Yeah.
These things
Control.
helps a lot. Just paste it.
Ah, this is ridiculous. This is I cannot. It's not working. Okay, let me copy again. It's command copy
Yes,
and then
I'm showing
command.
you as because it will help you and
But
it
it's
will
not
help.
working. It's not pasting.
Okay, I can do it.
Working. Oh, my.
I don't know. This is the problem in the Apple.
Okay, yeah, because it's not copying. Hmm.
Okay, I am sending you the explanation.
Mm-hmm.
Uh, okay, chat
Hmm. Where you send it in?
in here. Okay, now I am reading it now.
Okay.
You can see it. Okay, considering the patient's symptoms and examination finding, the most likely answer is E. Here is why. Numbness and weakness, they actually explain everything. Look at the explanation.
Where are you? Look, where are you? Where did you send it?
In your Telegram, or like in your, sorry, in, not in Telegram, sorry, in here, like in where we are reading. In Team.
Oh, in Teams. Okay, okay.
In Team, look at the chat box of the team.
Uh-huh. Okay.
Okay,
I
you
read.
read the explanation.
Uh, Considering the patient's symptoms or about E ulnar option. Here is why numbness and weakness in the left hand, specifically ring finger, small finger, hypotenuse. Okay, that we know.
Yes,
Atrophy of the hypotenuse muscle, weakness of the small finger. Okay, that we know.
yes.
Flexion of the middle ring, small fingers, ulnar cloud. This occurs due to weakness of the intrinsic muscles innervated by the ulnar nerve. Okay, okay. Inability to prevent paper from being pulled through the fingers. This indicates weakness of the adductor pollicis, which is also innervated by the ulnar nerve. Okay. Normal function of the intrinsic hand muscles. This suggests issue rather than more widespread nerve. Okay, this suggests a localized issue rather than the widespread nerve or spinal cord problem. Normal function of other intrinsic heart muscles. Okay. Normal deep tendon reflexes of the upper extremity. I thought deep tendon was low. Okay. This makes cervical nerve root compression is less likely as they often involve. But the deep tendon was 1 plus. I thought 1 plus was not normal.
One plus is not significant, yes.
Okay.
And lack of
Not-
involvement of the median nerve territory.
Okay, that we know. Lack of more widespread neurologic deficit, lesion of the lower trunk or the brachial plexus will involve more muscles in the forearm and hand than just those observed by the older nerve. Okay, I guess.
Okay, like kind of clear explanation.
Mm-hmm. Yeah, it's better than
It's
the
better
one
than
on the.
their explanation.
Yeah.
Okay.
Okay.
So whenever you don't found any answer, just do it in this way.
Mhm.
I don't know why it hasn't happened. Like you can copy and paste your answer.
I don't understand why it's not copying.
Where is
Uh,
the function of the uh, copy thing?
usually, usually it's okay. Let me maybe to get it from here. No, it's not letting me copy from here because usually they will say copy, but it's not saying it. I don't know why.
Okay,
Uh,
then I think that again you should start from like from A to the whole options. Maybe there is something. Okay, leave it. You can copy it.
mm-hmm,
I know.
mm-hmm. Okay. Next. 77
So
women
your
come to.
bigger questions are coming.
I know. It was so good for short questions. 77 women comes to physician because of 3 week history of lightheadedness. She says that she feels as if she's going to pass out when she gets out of bed in the morning. She has not had chest pain, shortness of breath, or palpitation. She has hypertension, hypothyroidism, hypo, current medication, thiazide, enalapril, and levothyroxine. She appears tired. BMI is fine. She's 6 feet tall. Temperature fine. Pulse fine. Oh, irregularly irregular. Respiration fine. What did I do? Yeah, respiration fine. Why is my thing always doing this? Okay, respiration fine. Blood pressure is high. While supine and is, I guess, normal when she's standing. Exam shows dry skin. Thyroid gland is symmetrically enlarged, nodular and non-tender. Jugular venous pulsations are present, 3 centimeters above the sternal angle, and decrease with inspiration. Huh. Lungs are clear. Grade 1 out of 6 systolic murmur heard best at the left sternal border without radiation. Trace pitting edema of the ankles. Neurologic exam is fine. Result of CBC are fine. Serum potassium concentration, I believe that is fine. And TSH is 1.5. Let me double check. Potassium is a bit low, but fine.
TSH
T,
is, I think, the normal 0.5 to 5.
uh, yeah, TSH is normal. ECG shows AFib with ventricular rate of 64, and its other was unchanged from the ECG 1 year ago. Which of the following most appropriate next step to determine the cause of the patient lightheaded? What's causing the lightheadedness?
It's not the thyroid cause, isn't it?
Probably not.
Because his thyroid things are all okay, as far I remember.
Large and nodular and non-tender.
Minor resistance. 1 by 6 systole murmur at the left sternal border. 1 by 6.
TSH.
Hypertension.
Serum, Sike. AFib. Mm, oh,
Okay,
okay. What is the other? Oh,
okay.
Jesus.
This patient's this patient is with this patient with symptoms of near syncope. She has symptoms perhaps of hypothyroidism. She has symptoms perhaps of hypothyroidism, but the presence of jugular venous distension and peripheral edema also support the heart failure. Jugular venous distension
Mm,
and the peripheral edema also support heart failure. However, since the patient has known tachyarrhythmia, atrial fibrillation, and slow pulse, there is most likely AV dissociation, which would be caused by six sinus symptom. Her serum TSH hormone concentration is within reference range. Although six sinus syndrome can be associated with severe hypothyroidism, her treatment suggests she may be undertreated, but not the point of likely causing heart block. An ambulatory ECG is needed to confirm the bradycardia because his ventricular rate is like low. Not low actually.
not really, no.
Yes. His ECG to confirm the bradycardia when has her current symptoms, and the treatment would ultimately be a pacemaker. None of the listed diagnostic studies. Okay.
Okay. I guess. 52 women has decreased urine output 6 hours after admission to the hospital for treatment of 3-day history of nausea and vomiting. She has type 2 diabetes, peripheral neuropathy, outpatient medication, glipizide, atorvastatin, lisinopril, aspirin. All medication were held on admission. Blood pressure is low after beginning IV administration of fluid. Blood pressure increases 110/70. On exam now, the abdomen is soft and there is diffuse mild tenderness, no guarding or rebound. Bowel sounds are decreased. Um, Decreased sensation to light touch over the feet. There is decreased sensation. Labs. On admission, finger still blood glucose 4 plus, and now it's 4 plus. Serum creatinine. Wait, urea on admission was high and is still high. Creatinine was high and still and is higher now. Ugh, that don't work. Urine, specific gravity, whatever. RBCs was 0 to 2 on admission and now it's still 0 to 2. Cast none on admission and now it's coarse granular, which I don't know what that means. Which of the following is the most likely explanation for this patient decreased urine output?
Creatinine is rising. So, no, square. Acting granular got fun. Got tribularies. Ball cells.
Mm,
Granular cast. That is the key. There is
mm,
no other key finding I am getting.
mm, 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 mm. Tubular necrosis, acute interstitial glomerulonephritis. Tubular necrosis. Everything was stopped. Bilateral hydronephrosis. Okay. Oh my goodness. Oh, why is he doing this? Ready?
Yes. Okay. These patients presented with hypertension, acute renal failure. This patient presented with hypertension, acute renal failure, which has since worsened and has developed coarse granular gas, suggesting acute tubular necrosis as a cause of her acute renal failure. Acute tubular necrosis is amongst the most common cause of AKI and is most commonly due to hypertension. The fact that the patient's AKI did not improve with fluid resuscitation suggests ATN as the most cause as the cause as opposed to prerenal azotemia. Uh, most common cause of AKI is commonly due to hypertension. The fact that the patient's AKI did not improve with fluid resuscitation suggests ATN as the opposed to prerenal azotemia. Acute glomerulonephritis is typically with hematuria in the absence of urinary tract infection, proteinuria, and may be present. Acute interstitial nephritis typically presents with eosinophiluria, and urine sediment typically shows white cells, red cells, or white cell casts.
Okay.
AIN. Okay.
42 men with alcoholism admitted to the hospital 12 hours after the onset of severe epigastric pain that radiates to the back. He has had several episodes of vomiting, temperature high, pulse high, respiration normal. I guess BP normal, kind of low. There is tenderness to palpation in the epigastrium and right upper quadrant of the abdomen. There are no signs of peritonitis. Bowel sounds are decreased. After 2 days, labs. Hemoglobin is 13, which I believe is normal. He is a man. Let me double check. MCV is high. Where is hemoglobin? Yeah, it's a bit low. Leukocyte count is high. Segmented neutrophil high. Uh, serum calcium.
Is very
Believe that
low,
is
isn't
it.
it?
Yeah, no. Yep. Urea. Believe that's high. Creatinine high. Albumin, I believe, is normal. Let me see, urea is high. Amylase, where is amylase? Where is amylase? Yeah, it's high. His serum electrolyte concentrations are within normal range. Which of the lab findings in this patient is associated with worse prognosis?
Yes, pancreatitis, isn't it?
Probably yes.
Okay.
I think. Ready? Yeah.
Yes. So serum calcium concentration. We need to see microscope to see this answer. Okay.
Yeah.
I have microscope. I have magnifiers. In my PDF, like in my reader, there is an option like magnifier. Okay.
Oh,
So sometimes I use. Okay. This patient's presentation strongly suggestive of acute pancreatitis. Given his history of alcoholism and epigastric pain, in addition to the back, several scoring system can help to predict the severity of the patient's pancreatitis. Ranson's criteria, being one of the earliest and the most commonly used, it is based on 11 factors that is measured, 5 at administered, 5 at admission, and 6 at 48 hours, each of which are assigned a point value of 1 if present. The table shows, okay, the criteria and the cutoff values. Okay, let's see the Ranson's criteria. Age more than 55. This patient's age is 42. Age more than 55, leukocyte count more than 16,000, glucose more than 200, LDH 350, AST 250, and at 48 hours, hematocrit more decrease by increase 10%. Urea nitrogen increased by more than 5 milligram per deciliter despite fluid resuscitation. Calcium less than 8, PO2 is less than 60, base deficit is more than 4, fluid resuscitation is more than 6,000. Okay,
mm,
so got how many score got in this patient? Like his
God.
calcium is low, less than 8, 1 point. PO2 is not given, base deficit not given, and the glucose LDH.
I ain't gonna lie. There's no way I'm gonna remember all these criteria on this. Like
Okay,
it's not, it's
okay.
not gonna happen. There is no way you can remember all these criteria
Like
on
they
this.
are like calcium, one of the markers. Remember, you need to
Yeah,
see the markers,
yeah.
like the severity markers, like calcium
Mm-hmm.
and the oxygen. Maybe we need to remember this too, and the urea nitrogen. Probably. Okay,
Mm-hmm.
leave it. You want me to read the other options?
Yeah, I can. You can eat all. Yeah, everything. Yeah.
Okay, I thought that it's over. Okay.
Mhm. Sure, sure.
Hypocalcemia at 48 hours is the greatest predictor of mortality in these patient, an elevated leukocyte count more than 16,000 at admission is associated with higher mortality. Is associated with higher mortality according to Ranson criteria, and only mild elevated leukocyte count at 48 hours is not associated with increased mortality, while the fall in the hematocrit more than 10% at 48 hours is associated with increased mortality. Slightly increased MCV is not. While some recent studies have shown that hypoalbuminemia in pancreatitis is associated with organ failure and death is severe hypoalbuminemia, the mildly decreased severe albumin in this patient is well above the cutoffs. With elevated MI, less can help to diagnose pancreatitis. Elevated 48 hours has been identified as indicator risk factor for mortality. Okay, so leukocyte count, calcium level, and the albumin. These are the three we need to remember.
And fall in hematocrit.
Yes, fall in hematocrit. Yes,
Okay.
these four things we need to remember.
Okay. Let's see if we remember that. Anyway. 32 men comes to the no 32 women comes to the ED because fever and cough with increasing production of purulent sputum for 24 hours. She has had asthma since childhood that is characterized by episodes of coughing and wheezing. Um, Treatment with inhaled steroids was begun 8 months ago. She has been hospitalized twice over the past 2 months for low-grade fever, increased sputum production, and poorly resolving infiltrate in the left lower lobe. Sputum culture at that time group normal flora and aspergillus. She is in respiratory distress, temperature high, pulse fine, respirations high, BP a bit low, diffuse respiratory wheezes and crackles are heard at the left lung base. Cardiac exam normal. Which of the following is the diagnosis? Oh, jeez. Mm,
Aspergillus fumigatus.
cystic fibrosis.
Alpha 1 antitrypsin deficiency is lungs and liver, isn't it?
Lungs and liver. Yep.
Pertussis comes with post-tussive emesis. It's not
Mhm.
Wegener. Wegener is C, like sinusitis, lungs, and kidney. Either cystic fibrosis or. So he has asthma since childhood. Okay, is it cystic fibrosis?
Yeah, it makes more sense, huh?
You
Yeah.
you can
But
choose your option. Okay,
yeah, it makes
because I
more.
am doing wrong these days. You are right previously. Why you change it?
No!
I don't say. I
No,
was
but it
talking.
makes
I was
sense.
talking.
No, when you said that since childhood, I was like, yeah, it makes sense. Like it was,
That's the thing has written. That's why that sparks me,
yeah, it
because
made
cystic
sense.
fibrosis start with the, but cystic fibrosis organism is not the aspergillus. We have chosen wrong. Cystic fibrosis organism is either pseudomonas or strep pneumoniae, as far I remember.
Yeah, and I feel like cystic fibrosis will have other complications than
Like
just
cystic fibrosis can cause pancreatitis.
pancreas.
Pancreatitis.
Yeah, yeah,
Yes.
she will have the
And
pancreatitis and
and
all that.
she it can cause the like infertility, like
Exactly. Like I feel like by now she's 32, she will have all these, things.
all these things can happen. Yes.
Um, whatever.
We we actually thought that CMS form. Okay, we underestimate the CMS form. Okay, the presence of Aspergillus fumigatus. The presence of Aspergillus fumigatus on sputum culture combined with uncontrolled asthma despite treatment with inhaled corticosteroid, and fixed infiltrate on chest X-ray makes allergic bronchopulmonary aspergillosis. The most likely diagnosis in this situation, a positive skin test against Aspergillus antigen and elevated IgE levels would be seen on labs testing. Bronchiectasis is often seen on CT scan. Bronchiectasis is often seen on CT scan. Alpha-1 antitrypsin deficiency typically presents with emphysema and can cause chronic liver disease. Other things we know. Okay, cystic
Mm.
fibrosis may present with chronic recurrent respiratory infection or symptoms of malabsorption. As patients' symptoms are more subacute and cystic fibrosis is more less likely, much less likely. Okay,
Got it.
it's a
7.
narrow miss.
Yeah, yeah. Previously healthy 37 woman comes to physician because of 2-year history of progressive shortness of breath. During this period, she also has had intermittent non-productive cough, wheezing, especially when she has cold during the winter. She has not had night sweats, no medications. She smoked for like 9 years. She's employed as a landscape architect. 60-year-old father has had emphysema since his early 40s. The patient appears well, pulse is fine, respiration fine, BP fine, lungs are clear, breath sounds are mildly decreased at the lung base. Where am I? Reminder of the exam is fine. Pulse oximetry 97, spirometry shows FPV1 is low. X-ray of the chest is shown. Most likely mechanism of this patient lung injury. I don't see anything on the chest this way. But FEV1 is low. Mm,
So
mm,
Paraltion.
Chronic infection with aspergillus, not aspergillus again. Mm, bum, 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 No normality.
She has more nuts.
Cardinality.
TV
Chronic irritation
is
function.
international protocols with when
Mm.
okay
Ready?
it's yes, is it emphysema, isn't it?
I'm thinking. Let's double check. Must be, yeah.
Okay, we are right. Okay. Mm, so these patients chronic dyspnea bouts of exacerbation along with family history of clear early emphysema markedly reduced FEV1 on spirometry indicates the most likely as emphysema secondary to alpha-1 antitrypsin deficiency of alpha-1 antitrypsin leads to unopposed proteolytic activity due to insufficient inhibition of the neutrophil elastase. Chronic exposure to environmental antigen allergen. Chronic exposure to environmental allergen may lead to chronic hypersensitivity pneumonitis, which would typically lead to bilateral ground glass and reticular infiltrate with centrilobular nodules on imaging. Chronic infection with Aspergillus fumigatus can be seen in patients with chronic lung disease such as ABPA in patients with asthma and is characterized by transient pulmonary infiltrate and bronchiectasis. Lung cavities may also be infected with Aspergillus and classically associated with cavities or with air fluid levels and defense of fungal bugs. Okay.
Okay. 62 men comes to physician because moderate right leg pain for 2 days. He has metastatic non-small cell cancer of the lung and completed palliative chemo 3 weeks ago. Takes now the medications, temperature fine, pulse fine, respiration a bit high, BP high, gets high. Cardiopulmonary exam is fine. Labs hemoglobin a bit low. Platelet, guess that's normal. PT and PTT. Let me double check. Where is it? Where is PT? Oh, PT is normal and PTT is normal. Serum creatinine normal. Venous Doppler ultrasound of the right lobe shows thrombosis of the common femoral vein. Which of the following is the most appropriate next step in management? Oh. Hmm. The wicked is it?
PT is normal, isn't it?
Everything
PT.
is normal.
Yes,
Everything.
everything is normal.
So
Chemo, he has got chemotherapy
uh,
3 weeks ago.
wicked warfarin or heparin? I forgot what was the difference between the two.
Sorry, for chemotherapy.
No, not for chemo. For the DVT, do we give warfarin or heparin?
Heparin.
Heparin. Okay. Ready?
Yes. So it is chemotherapy induced DVT,
I don't know if it's
like
the chemo that
malignant
caused. Oh,
malignancy.
malignancy. Malignancy causes the DVT. So. I mean, but it's clear that he has DVT. They said the ultrasound shows thrombosis of the. I mean, they're telling you he has DVT.
Yes. But why PTT is not high? Like, okay, may not be high always. Okay. These patients with these patients with metastatic malignancy which presents with acute leg pain. These patients with the metastatic malignancy which presents with acute leg pain. DVT stands deep vein thrombosis stands out as the most likely diagnosis, and the femoral ultrasonography confirms the presence of deep vein thrombosis. Low molecular weight heparin such as enoxaparin is the treatment of choice. Enoxaparin is the treatment of choice of both prevent or and treat the DVT, deep vein thrombosis in malignancy. Warfarin therapy is reasonable choice for deep vein thrombosis not related to malignancy but has delayed onset of effect and may inhibit protein CNS before inhibiting the clotting factors. If warfarin is used, there must be a bridge with warfarin and heparin. There must be a bridge with heparin and warfarin, low molecular weight heparin. Okay.
Moderate obese woman has 4-year history of recurrent abscesses in both axilla. They are progressively more frequent and severe. The episodes are interfering with her ability to work. She has diabetes that is fairly well controlled with diet and use of, I guess, drugs. Which of the following is the most appropriate management? Ready?
Wait, one sec. One second. Mm, okay.
Okay. Oh,
Quite uh, quite different. Okay. So, surgical excision of the apocrine gland. Wait,
never heard that.
sorry,
I haven't heard that one yet. Treatment
this.
for I diagnosed it well. I knew it was hydradenitis, whatever, but I did never heard that as a treatment.
Okay. So the patient likely has hidradenitis suppurativa and inflammatory hidradenitis suppurativa and inflammatory conditions of the apocrine gland. This patient's disease pattern demonstrates progressive symptoms and exacerbation that are affecting her quality of life. In this case, the patient's type 2 diabetes mellitus is well controlled, so insulin therapy is not needed. Likely poor glycemic control would not substantially alter her risk of for infection. Long-term administration of antibiotics would not alter the clinical course and have side effects. Silver sulfadiazine would not have effects on symptoms, and daily washing may have benefit, but given her symptoms and decrease the burden, surgical excision would be treatment of choice.
Okay. 23 woman comes to the ED 2 hours after the sudden onset of sharp anterior chest pain. She says that the pain is worse with respiration and when she's supine and is relieved somewhat when she sits up. She took two acetaminophen tablets 1 hour ago, but they have not relieved the pain. No history of similar symptoms or serious illness, no medications, temperature high, pulse high and regular, respiration normal, BP just normal low. A two-component fracture rub is heard at the apex. The remainder of the exam shows no abnormality. ECG is shown. Most appropriate initial step in pharmacotherapy.
What is your diagnosis?
Looks like
Uh,
pericarditis, but I haven't looked at the ECG. But I'm just gonna assume it's pericarditis. I'm not even gonna try to read the ECG.
Okay,
Just,
okay, it's pericarditis. You
yeah.
are right. This patient with a 23-year-old woman who has sudden sharp chest pain with positional relief and a frictional rub. An ECG shows diffuse concave ST elevation, which make pericarditis the most likely, which shows pericarditis the most likely diagnosis. A myocardial infarction is not likely based on the lack of the risk factor. Physical examination and morphology of the ECG. In the setting of acute pericarditis and non-steroidal anti-inflammatory drugs such as ibuprofen are the initial treatment of choice, usually in conjunction with colchicine.
Okay. 77 woman with osteoporosis and hypertension admitted to the hospital because progressive confusion during the past 5 days. Husband reports that she had had constipation for the past week and abdominal pain for 3 days. He had dry breast cancer treated with lumpectomy and radiation 2 years ago. Medications, alendronate, thiazide, calcium supplement, vitamin D. She's alert, temperature fine, pulse fine, respiration fine, BP high. Pulmonary exam is fine. Abdominal shows mild distension and tenderness. No guarding and no rebound. Rectal exam shows hard brown stools. The neurologic is fine. Mental status, she has been anxious and is not oriented. Serum calcium concentrate is 14.8, which is high. And albumin is 3, which I believe is low. Let me double check. Yeah, it's low. CT scan of the head with no contrast shows multiple skull metastasis. Strongest contributing factor for this patient hypercalcemia. Oh, what's causing the hypercalcemia?
Ah, I will say calcium supplement of an island.
Bronchogenic carcinoma.
Is it
Oh, no. Ready?
okay?
Okay, 21.
Okay. Recurrence of breast cancer, the clinical manifestation. The clinical manifest. This is the hypercalcemia of malignancy.
Yes.
Okay, this patient has clinical manifestations of hypercalcemia. Hypercalcemia with altered mental status and constipation. Altered mental status and constipation confirmed with elevated serum calcium. Of etiologies hypercalcemia, malignancy is the most common, with breast cancer being the most common malignancy in the US. Multiple bone metastasis of the skull in the patient point further towards the malignancy being the cause of her hypercalcemia and the most likely source of being the recurrence of her previous cancer. Okay.
Okay. 26 men brought to the ED after vomiting bright red blood twice in the past hour. He appears robust and comfortable. Pulse is high. Oh, what happened? Pulse is high. BP is low normal, while supine. There is mild epigastric tenderness. Test of stool for occult blood is actually negative. Hematocrit, I believe that's normal. This one? Which of the following is the most appropriate next step in management? Let me see hematocrit. Hematocrit for is a bit low normal. Next step in management is vomiting bright red blood. Um, repeat hematocrit. Measurable of serum release. Ready?
Okay, yes. Okay, in the setting of hematemesis and the tachycardia, the patient in the class 2 hypovolemic or hemorrhagic shock, the class 2 hypovolemic or hemorrhagic shock with a likely blood loss 15 to 30%, with a likely 50 to 30% of their circulating volume. Volume resuscitation is the most appropriate next step in the 0.9% sodium chloride. Okay.
Okay. 55 woman comes to the ED because of fever, nausea, vomiting, diarrhea, decreased urine output for 2 days. She has 8-year history of diabetes treated with peptide. No history of renal disease. Temperature is high, respiration high. While supine pulse is high, blood pressure is 116 over 70. While sitting, pulse is high, even higher, and blood pressure is super low. She appears acutely ill and slightly lethargic. Exam shows decreased skin sugar, dry mucous membrane, and flat neck veins. There is mild generalized abdominal tenderness without guarding. Labs, leukocyte count is high. Where am I? Sodium is normal, but chloride is normal. Potassium is actually low. Bicarb is normal. Urea is high. Glucose is high, creatinine is high, urine, uh, pH acidic, glucose 2 plus, ketones trace, and sodium, I don't know, this 8. That's the diagnosis. Do you have any rash? No, she doesn't have any
Membrane margin venous flat,
neuropathy,
decreased skin tone,
glomerulonephritis, renal
glucose is high,
insufficiency.
creatinine is hypochondria,
Oh my goodness, why is he doing this?
nerves.
Ready? Maybe not.
Okay, this patient has decreased urine output and increased BUN and creatinine. Decreased urine output and increased BUN and creatinine indicate acute kidney injury. Her exam her exam shows signs of dehydration. Her exam shows signs of dehydration, dry mucosa, decreased skin turgor, and IV volume depletion evidence by orthostatic hypotension and tachycardia. If available, a urine creatinine would allow for the calculation of the fraction of the FENA, which given the low urine sodium and is likely to be quite low, with the clinical presentation pre-renal azotemia one of the most common etiologies of the AKI and the most likely diagnosis. Okay.
Can you read the other ones?
Yes, acute interstitial nephritis is usually seen in the context of the initiation of the new medication and is usually associated with the eosinophil in the urine, which is not seen in this scenario. Acute tubular necrosis can arise from multitude of the different clinical scenario on different clinical scenario, and its diagnosis is reversed. Sorry, its diagnosis is reserved until both prerenal and postrenal causes of AKI are ruled out. In the absence of physical signs and the symptoms of the urinary retention and the hydronephrosis readily seen on bedside ultrasound, obstructive uropathy is much less likely. Post-infection glomerulonephritis typically presents about 2 weeks. Okay.
62 hmm, woman, progressively back, severe mid back pain over the past month. She has been fatigued and less mentally alert for 3 weeks. Month, fatigue and mentally, okay. Temperature is fine, pulse is fine, respiration fine, BP. That's a bit high. Aye. The reminder of the exam shows no abnormality, except for impaired cognitive function. Labs, hemoglobin is low, hematocrit is low, leukocyte high, calcium, I believe that's high. Let me double check. Yeah, it's high. Urea high and creatinine high. Serum electoral concentrations are within normal. Leaving X-ray of the chest shows no abnormality. X-ray of the skull is shown. Most appropriate next step in evaluation. Hmm. Mid back pain, fatigue, and less mentally alert. Um, hmm,
Is it MM?
what's MN again?
Multiple myeloma?
Probably, yeah. One scan, CT scan of the head, renal biopsy, multiple myeloma. So, do we do protein? Okay, ready?
Okay, this patient is a 62-year-old woman with progressive mild back pain and anemia and elevated serum creatinine, including indicating renal failure, which is a classic triad of multiple myeloma. Okay,
What is the triad again?
like the crab. hypercalcemia, renal failure, anemia, bone pain, light occlusion. They have told in a different way, like light occlusion on the X-ray, light occlusion on the X-ray, and the next step of the diagnosis would measure urine or serum protein electrophoresis, ideally with immunofixation.
Okay.
But if you remember the craft feature, then it would be all right.
Mhm. Next, 2 days after MI, um, a previously asymptomatic system woman develops pulmonary edema. Oh wait, okay. A grade 4 out of 6 systolic murmur is heard at the apex. Oxygen saturation, right atrium and pulmonary artery is 65%. Pulmonary artery diastolic pressure 35. That is the diagnosis. Wow. Mm,
And the apex, pulmonary edema, that's but
mm.
what's your thought? 4 by
Mm,
6 systolic murmur heard at the apex. Is it MR?
4 to 6 is yeah, but apex is always yeah MR. It's always sorry, it's always mitral, so it must be.
If we think about that box, prom, papillary muscle rupture,
Maybe.
papillary muscle rupture. Okay,
Okay.
papillary muscle rupture. Okay. This patient symptoms consistent with mitral valve regurgitation with decompensation a loud systolic murmur at the apex and the pulmonary edema, a loud systolic murmur at the apex and the pulmonary edema, lower oxygen saturation in the right circulation and elevated pulmonary artery pressure. Within okay,
Yeah, can you read that one?
within 2 to 3 days after MI, the risk of papillary muscle rupture. Within 2 to 3 days, the risk of papillary muscle rupture is the highest, making an acute rupture of the mitral valve the most likely an answer. The ruptured interventricular septum might produce symptoms, but oxygenated blood from the left ventricle would enter the right, and it would make the oxygen saturation higher. A ruptured left ventricular. Okay,
Okay. Next. 32 men brought to the ED 30 minutes after he was found unconscious on the floor of his apartment next to a bottle of barbiturates. On arrival, pulse is high, respiration low, BP low. Is intubated, mechanically ventilated. Exam shows diffuse movement, too painful stimuli. Labs, sodium is fine, but the chloride is a bit high, fine. Potassium is high. Bicarb is low. Urea is, where am I? High. Creatinine super high. CK, I believe that's high. Urine, blood positive, glucose negative, Protein 3 is RBCs 3 to 4. White blood cells
Okay.
0 to 2. Aye, this my thing don't work no more.
RBT.
And pigmented granular cast is 4 to 5. Which of the following is the cause of this patient? Renal failure. Patient. Oh, let me do that. Be 27 over 27 over 5.7. Okay, so it's not the renal. Pum, 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 pum. Glucose, there is blood. IBC. Ah, cholesterol embolization. Debated and mechanically ventilates. And CK. Oh, are we wasting so much? I'm like, why am I wasting so much?
Well,
Sorry,
I was waiting for your answer.
sorry, sorry,
No, no,
sorry.
no problem.
I didn't see. I didn't
It
see. I forgot the
happens
see.
plenty of time with
I forgot the see. I didn't look at. Sorry, sorry.
me. Okay, so it's rhabdomyolysis. Everything is breaking down. So this patient is this is a sorry this is a patient who was found unconscious for an unknown amount of time with an anion gap acidosis, high serum potassium concentration, and moderately elevated CK. The results the results of a urine dipstick shows um, the results of a urine dipstick show blood, but results with urinalysis showed erythrocyte count was within the reference changes. Okay, these all suggest rhabdomyolysis breakdown of the mast cell and is characterized by high serum potassium concentration. Myoglobin is present on the urine. Okay,
37 woman comes to physician because she has been amenorrheic for 3 months. She also has had increased facial hair growth and multiple episodes of acne over the past year. She has had weight gain, like 60 pounds, during this time, despite no change in appetite. Menses had occurred at regular intervals until a year ago. When they became increasingly irregular, she's not sexually active. BMI is high, BP high, exam shows truncal, she's fat and pink striae. Reminder of the exam is fine. HCG is negative. Measurement of which of the following is the most appropriate next step?
is it PCOS? PCOS.
Sounds like that one, but sounds like that one, but then hmm, they had aldosterone sulfate, urine free cortisol. I think is a adrenal gland issue, but now I don't know if it's free
Congenital adrenal
cortisol.
hyperplasia.
It's some kind of adrenal issue, but I don't know if it's like the free cortisol or the DHA. I will check.
Okay,
Okay, ready? Between A and D, I just and E has new.
we are
Ready.
out of
I knew it's not
Cushing.
PCOS. Yeah, it's not PC. It just
What we missed? Oh, this patient has facial hair growth.
no. I knew it wasn't PCOS because it's like the blood pressure and then the yeah, it
But
wasn't
in PCOS, blood pressure is high. There is acne.
But then
It,
look at the pinks try the trunk. I mean, they gave you a
okay,
lot
oof,
of things, yeah, to say it's not fixed.
that's
I
the
knew it
Cushing
was,
thing. Oof.
yeah.
That was Straya.
Yeah.
Why I haven't? That's pushing. It was easy. Missed.
I knew it was I knew it was some kind of cortisol, but I just didn't know if we checked the whatever. Anyway, read it.
The patient has secondary amenorrhea and pregnancy was ruled out. Secondary amenorrhea and pregnancy was ruled out. The fairly recent onset and fast progression of weight gain and hirsutism along with biological stria in the absence of exogenous corticosteroid should raise suspicion of Cushing syndrome. First-line testing of Cushing syndrome should include measurement of 24-hour free cortisol concentration. This clinical picture also raises concern for hyperandrogenism, which is a sign of androgen-secreting tumor, which would lead to elevated serum dehydroepiandrosterone concentration. However, this condition is more in postmenopausal women. Okay, you
Hmm.
are right. If it is postmenopausal woman, measurement of
Postmenopausal.
estradiol and progesterone would be warranted in evaluation of the amenorrhea. However, the clinical features of hypercortisolism makes Cushing syndrome likely. Okay,
What did they say that if she had hyperandrosten,
L-
whatever, high
like
androgen?
yes,
Uh-huh.
if this clinical scenario raise concern for hyperandrogenism. If
Uh-huh.
there is hyperandrogenism, that means androgen secreting tumor, and in androgen secreting tumor there is a DHEA would be high, but
Mm-hmm.
it is more common in postmenopausal women, not like this kind of amenorrheic like premenopausal women. The
Okay.
similar scenario without the pink stria and rest of the thing is here looks like that DHEA.
Okay. 67 men type 2 diabetes comes to physician because of 2-day history of increasing pain and redness in his left knee. Pain and redness. Okay, 10 days ago, he spent several hours in his knee waxing the floor. His knee has been somewhat solid and painful since then. Temperature high, pulse sugars normal, BP normal. Anterior aspect of the knee overlying the patella is red, and there is fluctuance in this area. There is no effusion. Range of motion of the knee is full, and any movement of the knee produces minor discomfort. Diagnosis.
History of increasing pain and redness of the left knee waxing. What is knee waxing?
Knee waxing on his knee. Oh, waxing the floor, like cleaning the floor.
Okay, so
That way is the face answering. Oh
regular.
no. Ready?
Okay, prepatellar bursitis, housemaid's knee.
Mm,
If you don't say the knee, then okay. This patient, this patient is a 67-year-old man with type 2 diabetes mellitus who comes to the office because of redness over the anterior knee after working on his hands and the knees 10 days ago. After working his hands and knees 10 days ago, he has a fever and his joint examination discloses good range of motion, but is a tender and the red anterior patellar aspect. These patients' patellar septic bursitis is common for those on their knees for sometimes, and the fever suggests infection. Okay,
can you read? Where am I? D, E, and F. Just read everything.
Yes, the joint might be red, but there are no other skin findings such as varicosities. The range of motion of the knee is intact, which makes inflammatory bursitis of the face and serone's unlikely, and also making gout and the septic arthritis less likely. A Baker's cyst is located in the popliteal fossa, and Osgood-Schlatter disease, osteochondritis of the tibial tibule, typically presents in the adolescent or young adult, and the onset that present increases in the gradually over time, and is typically is not associated with swelling or erythema. Should choose news reading as
You
my
should.
second profession.
Definitely. Previously healthy 24 woman comes to physician because itchy rash on face, arms, and hands for 2 days. She notes that the rash appeared 2 days after working in the garden. Exam shows urticaria and vesicular lesion over the face, upper extremities, and hands. Most likely pathologic process of this patient rash.
Is it contact something?
Mm, mm, mm,
Mm,
mm.
mm.
I mean, I don't know. Ready?
Okay,
Oh, Lord. Okay.
okay. This patient has contact dermatitis that is most likely caused by a plant of toxin and poison ivy. This
You
dermatitis is a type 4 hypersensitivity reaction to the toxin, which is cell-mediated hypersensitivity caused by helper T lymphocyte. The SAP does not cause photosensitivity, direct injury, and chemotaxis and IgG antibodies. Destruction would be a type 1 or type 2. Okay,
what is the sap?
I don't know actually, so I can't say.
Hmm. Point sap. Way that transport water nutrients. Okay. I guess the inside of the plant. Okay. Okay. Where am I?
You are
Eh,
doing which block? Like random blocks.
Oh yeah, random blocks.
Okay.
57 man comes to physician because of 3-month history of mild shortness of breath with exertion in it. Episodes of dyspnea and muscle pain. Oh, why is it doing this? Episodes of nausea, sorry, and muscle pain. He received diagnosis of type 2 diabetes 8 years ago. Current medication, glyburide, metformin. Weight, BMI is high. Blood pressure high. Reminder of the exam fine. Labs, hemoglobin. A1C is 9.2%. Urea, I believe that's high. Glucose high. Creatinine high. Total bilirubin normal. AST and LFT normal. Most appropriate change to this patient drug regimen is the yeah. What would you change in the patient drug regimen? What is he taking? Well, he has diabetes.
Glyburide and metformin. He's not taking any antihypertensive,
Any antihypertensive? No. Increase
but
glucose.
he's
But his glucose is not even well controlled. Okay, hypertensive is not an option.
yes.
Function diaper anime for Minerva and intermittent insurance. Okay, ready?
Okay,
Oh, oh, wait. What is the question? What is the answer?
no answer. I
Mm,
don't have answer to. Okay,
okay,
I am looking for
yeah.
the answer in the.
Mm-hmm.
Let's see. You try to copy by yourself, then
If
you
that.
can learn. They are saying that answer A at like I'm sending you
Okay.
the explanation.
I think don't copy. I don't know what's happening with this shit. Okay.
You can find.
Yeah, it's not copying. It's doing the same thing as
I
before.
don't know why it is happening.
Nice. Mm. Given the page. Okay. Okay, you can read the explanation.
Okay. Add intermittent acting blue insulin. Sometimes they are wrong, but 95% they are correct. I am,
There.
yes, you know it, isn't it? But
Mm-hmm.
as they are explaining so well, so you can pick the answer. Okay. Why I am saying that? Am I the am I promoting Gemini?
Yes, yes, you are the number one promoter, Gemini.
Okay, poor glycemic control. His HbA1c is 9.2% and significantly above the target, like 7. For most non-pregnant adults with diabetes, this indicates his current oral medication, pivurine and metformin, are insufficient to manage his blood glucose levels effectively. Mm, Symptoms suggesting of poor control, elevated fasting glucose and creatinine. Elevated fasting glucose, the fasting glucose mode 278 is very high and confirming poor glycemic control. The elevated creatinine is 2.8, suggests possible early diabetic nephropathy, suggests a long term, suggesting long standing poor uh, control of the diabetes, suggesting poor control of the diabetes. Okay, okay,
Oh,
we can
yeah.
start tomorrow. Like we
Okay.
can, okay, you will start like you are